I'm Dr. Strube. I'm an associate professor in ophthalmology at Queen's University in Kingston, Canada. And Dr. Wright is here as our main speaker, and he really needs no introduction, but I'm going to introduce him anyways. He's contributed to our field for over 40 years. You know, Ken's contributed a lot in terms of how we think about strabismus, how we treat it, with many innovations, some of which we'll discuss today. But I just want to emphasize, I think Ken's, Dr. Wright's most passionate about education and sharing his knowledge with everyone. And so we're really happy to be able to share his knowledge and what we've experienced over the last few decades. I was fortunate enough to be his fellow 16 years ago, and I'm still continuing to learn from him every day. Anyhow, without further ado, let's get started. Ken.
So I do have a very small interest in the Color Atlas of Strabismus Surgery, the new edition with me and Ning Strube coming out in a few months, actually. And the royalty is horribly small. I put this other book online free, and that's Wright Strabismus Review, crazy easy. I try to make it as simple and easy as possible. So fundamentals, it's not important, it's critical. And unfortunately, I noticed that a lot of people really don't understand the fundamentals. And how does an eye move? I guess that's the first thing. And rotational force, the rotation of an eye. It's the moment arm, the lever here in M, and also the tension of the muscle. The longer the lever, the more rotational force, and the shorter the lever, less rotational force. Obviously, if you relax a muscle, it cannot pull as much. That's Starling's curve. And you see that it's exponential. In other words, if you slacken a muscle, you lose force, but then if you slacken it a little too much, you absolutely lose all force. And you see that in a stretched scar where a muscle pulls back, even a few millimeters more than maximum recession, and the muscle will lose its force. And the maximum recessions for the medial 7, laterals 9, inferior rectus 6 to 7, and superior rectus is 7 to 8. However, if you have a very tight muscle, you've got to ignore this and recess it more. But that's just a guideline for maximum recession. So when you recess a muscle, you take the muscle off, you move it back, you make it weak. Okay, everybody knows that. But what's interesting is you really don't change the lever arm, the moment arm in primary position. But what happens is you weaken the rotation towards the recessed muscle. When you rotate the eye towards the recessed muscle, the muscle actually gets more slack, weaker, and the moment arm diminishes. So if you recess a muscle, it has trouble moving over to that recessed muscle. And if it's over recessed, it won't rotate. So here's a patient with an exotropia, and it's commented, it's small. I figure, it's not much of an exotropia, but she wanted surgery. She bugs her. Friends were laughing at her. I don't know. She's 50 years old. Who cares? But she cared. So she tells me the right eye's drifting. And I say, no, we need to do both eyes. Otherwise, you will have incompetence. You will create a deviation in another field. Well, she's my right eye drifts. She just wants surgery right eye. So I recess the right eye 6 millimeters. So here's the right eye. I recess it 6 millimeters. And guess what? Now this eye doesn't rotate out. So the other eye overshoots. The operated eye, recessed lateral, the eye doesn't go out quite as well. The ductions are full, but just a little limitation, so this one overshoots. And guess what? It creates an esotropy in side gaze. So now she's mad. She says, I see double when I look to the side. And I did this on quite a few patients early in my career because I was told you do an R&R, recess, resect. You only operate on one eye in intermittent exotropia. And not all, but a high percentage of patients had esotropia in side gaze and weren't happy. So in this case, I went back, I advanced my 6 millimeter, and I recessed the other lateral, basically gave her bilateral lateral rectus recessions, and she did well. My point is, if you have a comitant deviation, do comitant surgeries. So you got an XT of 20 in primary, and you have XT of 15 in side gaze, do bilateral lateral rectus recessions, and you'll have maybe, if you're lucky, a small exome primary. She fuses this well, and ortho and side gaze. If you have a comitant deviation, do comitant surgery. Now, if you have a blind eye or dense amblyopia and poor vision, obviously in that case you do one eye. But if you have a comitant patient with fusion and the ability to see double, I suggest, especially for intermittent exotropia, do bilateral lateral rectus recessions, symmetrical surgery for asymmetrical strabismus.
Ken, I'm going to
Now,
interrupt you
why?
because
I
you made
thought
a,
it was brilliant.
you made
Wait a
a
minute.
really good point.
I thought it was brilliant and you're interrupting. Okay, good. Go.
See how young this 50-year-old looks? And I think that your point about you and I had a patient who I think was 92 in your clinic and was bugged by the appearance of it. So even our super old patients who are functioning well, the cosmesis of it really bothers them at all ages, not just in young adults.
That's a very good point. That's very true, but you did interrupt me, Ning. Okay, no, that's a good point. And so um and they too, if they have a comitant intermittent exotropia, even if they think one eye. So what I do often is I'll take a picture of the deviated eye. Can you see my hands, Ning? Okay, so you got a deviated eye. So I'll take a picture with one eye, the left eye fixing, right eye out. Then I'll cover, make them fixate with their non-preferred eye, and take another picture. And I show them that actually both eyes drift. And they go, oh my God, I didn't realize both eyes drifted. So that's a way you can inform them and show them in the photograph and put it in the chart. I put photographs. I have an EMR, electronic medical records, I developed with my fiance. I can put the photographs in easily. So I like putting the photographs in. So if anybody says, why'd you do both eyes? I can show them. And by the way, what law is that, Eni?
Hering's Law.
Hering's law of reciprocal innervation. Very good. Thank you.
Phew. Okay,
What am I doing now? Can I keep going?
keep going.
All right. I'm crashing and burning. How am I doing?
We're good. I'm keeping track of the time, and there's no questions and answers, so it must be clear.
As mud. Okay. All right. Resection. Now look, resection, you remove part of the muscle and then you advance it. We all know what a resection is. So this photograph is after the resection, and here we can see pulling a muscle up to the insertion after removing part of it. That is a resection. And many years ago, I developed a plication where you put your sutures posterior, you anchor them to sclera in front of the muscle and pull it up. There is a small fold, which you can see in the photograph, and that fold goes away. Let me go back. That fold goes away over about 2 to 3 weeks. So I like the plication because it's safe. You cannot have a lost muscle, virtually cannot. I like it because it's semi-reversible. And in the question here, polling question number 1. What does a resection or plication do? Strengthen the muscle, tighten the muscle, reduce the moment arm, increase the moment arm. Yeah, well, that's what I thought. Unbelievable. That is exactly what I thought when I wrote the first edition of the Strabismus Atlas, probably 35 years ago, not 40, but 35 years ago. I wrote that book right out of fellowship, and I wrote it as strengthening procedure. And my resident at the time, I was at University of Southern California, I was a professor, and the resident says, how the heck can you strengthen a muscle? It's not clicking for some, it's not advancing. There we go. It tightens the muscle. It doesn't strengthen it because my resident asked me, Dr. Wright, your book says a strengthening procedure, a resection or plication, but how do you strengthen a muscle if you remove part of it or isolate part of it? It's not going to be stronger. It's going to be tighter. And I go, you're very smart. And that was Dr. Mark Borchert, who was a neuro-ophthalmologist now, but he was a resident. And he asked me, he says, I think you misnamed the procedure. And he's right. And recently, a big dog ophthalmologist, Strabismus person in a big university wrote it's a strengthening procedure recently, just a couple of years ago. And I wrote to the editor, no, it's not the strengthening, it's tightening. Why is that important, Eni?
Are you
Because I'll tell you why it's important.
determines your surgery?
It determines your surgery. Because if I resect this muscle in dark here, do you see that with the red lines? If I resect it, I don't make the muscle work harder. It doesn't rotate towards the muscle. In this case, it wouldn't rotate more to the left. It stops rotating to the right. And if you don't understand that, you cannot use a strengthening procedure to correct incompetence. And let me show you a case. So I want to make sure this is clear. If I resect this dark muscle, the eye cannot rotate away from the muscle. It doesn't rotate better towards it. It doesn't strengthen it. It tightens it. Is that clear? It's so important. And most people don't know that, as we saw in the poll. So if I have a patient here with a sixth nerve palsy who gets better, and it's a right sixth nerve palsy, the right eye still gets out. He recovered, but there's slight limitation. So the other eye overshoots Herring's law. He tries to look this way because this eye has a normal medial. The eye turns in too much, and you have a small esotropia on side gaze. Lee Ening, have you seen that patient?
Yeah, it's very common. I cover Emerge Clinic all the time, and
You see it all the time, and you see it maybe if the right eye had a previous surgery and the tight medial, it's not going out. So it's not only with palsy, but it happens with a tight medial. So I see this a lot where there's side gaze esotropia, which they don't like. If there's a little exo, they confuse it. But an ESO and side gaze. And this reminds me of one of the first patients I had, came in from Harvard, flew in. It was the aunt to one of our surgery center technicians, and I just was in practice. And they were told at Harvard, and this is a true story. I don't make up very many stories. Some I do make up, but this one is true. And the patient had virtually small esophoria in primary, nothing in side gaze, and a bigger ESO here in this case in right gaze, because the right eye wouldn't abduct fully, minus a quarter, minus not even a quarter, minus trace. So that the good eye overshoots. And they wouldn't operate on her. So I operated on her. And I said, all I have to do is recess this medial rectus a little bit, it will stop it. And if I create an exo, that's fine. People love exos. They fuse, normal people fuse small exos. What do you think, Amy? So I just recessed the medial rectus. It took 20 minutes. She was so happy. So every time I saw her in follow-up, she'd come once a year, fly in from Boston, and she'd slip me $100. But I never told Doheny. I hope they don't hear this. So I took $100 under the table, and she loved it. So in this case, I can recess this medial, and you'll see here, and that'll stop the overshoot. And even if I create an exo in primary, who cares? This is a slam dunk. This is an easiest case in the world. What else could I do? I could tighten the lateral to stop it from going over, because tighten the lateral is not a strengthening procedure. It acts as a tether so you don't see over. Now, how could I tighten that lateral just a little bit? Central plication, not a full plication, not a full resection, just a partial plication. I'll show you that later. And Dr. Strube is going to be showing you that in the lab session.
And can I interrupt you again? So go back to your last slide.
Yes.
So what angle and also for our listeners, what angle are you using to guide how much recession or plication to do on the left eye?
That's a very good question. You don't do 6. I go 16 or maybe 12, but you overshoot, because if you leave a little exo here, they're happy. If I leave an exo of 6, that means I operated for 12. Does that make sense? I have a 6. So if I operate for 12 and I overcorrect, I got an X of 6 in primary. That is normal exophoria. Everybody, most normal people have a small exophoria, because our convergence is super strong. It's 20 prism diopters. It's nothing. In fact, that is normal to have a small exophoria. So I would shoot for like 12 to 15.
Thank you.
And so my plication, 6 to 8, don't hesitate. I'd probably do a plication of 6 millimeters instead of 5.
Central
Super
plication.
happy. Yeah. And by the way, all these people gave me permission to show themselves. They're happy to be on the presentation. Now,
Ken, I'm
if
going
you
to ask a quick question we have a few questions from the Q&A. Some of them are going to be addressed in the next few slides, so I'm going to put a pin on that. But the first question asked, what about small angle esotropia, which is comitant under topical? Would you do unilateral muscle or bilateral medial rectus recession to avoid incomitance?
Very good question. I would do one of my new minimally invasive surgeries. So I'm going to show you central plication. With central plication, you can get small amounts of changes. And so I would do bilateral central plications, and it only takes 10 to 15 minutes to do a central plication. I'll show that. That's a good question. But I keep hearing about R&R, recess resect, or recess plication. And if you do that, like in one eye, as you see in this slide, you can see the red indicating we do a recession resection. You limit eye movement, and you will see esotropia in side gaze. And it can be quite large because when you recess a muscle and then you tighten the other muscle, it really can't move over. Does that make sense? You've you've recessed the agonist and you've tightened the antagonist. The eye doesn't go over, and the other eye, which moves freely, overshoots Herring's law. And you also will always have an ET and side gaze if you do an R&R for a large exotropia. Now, I always say this, and Enid's going to remember this. If you want to go fast, go slow in surgery. And keep going. So many times people hesitate, they look, they dab. Keep going. And I operate slow, but they say I'm the fastest strabismus surgeon at the surgery center. But we don't screw around. I'll tell jokes, whatever, but you keep moving. Now, in strabismus, you want the chin up and you want the forehead lower than the chin so the patient is looking back to the surgeon. Set up properly. I put tape around the bonnet so hair does not get in the field. I don't want hair in the field, very dirty. Now, you can use limbal incision. I'm going more to a limbal incision. I used to do fornix in the children and limbal in adults, but I like limbal more now, and I'll show you why later in this slide. And limbal is fine. When you hook a muscle, and see my hand, Ning? See my hand? No?
Yep, I see it.
Your hook should be perpendicular to the sclera and then slide under the muscle. If you start flat, you'll penetrate the muscle. Does that make sense? So in this diagram, if you look closely, this is a small Stevens hook. It's perpendicular to sclera and then it slides under the medial. Here we see a large hook, Stevens hook or Green's hook, Jameson hook. It's perpendicular and it's going to slide under the medial, which is already hooked by the small hook. Most people, when they hook flat. No, you want to be perpendicular because the eye is rounded. If you're flat, you can see you'll penetrate the muscle. Now, I invented this some years ago. I no longer make any money on it because the patents run out and they're selling it. I think it's Titan Surgical. And I replaced the large hook and I put in the grooved hook, and especially a tight muscle, and you can suture over the groove, and that way you protect the sclera, and it also in a tight muscle brings that muscle into the surgical field. I like 3-point fixation, and I use 5-0 vicryl. You can use 6-0 vicryl. And I put a central security cinch and knot here. I pass twice in the center, then tie it, and then I do the locking bites each edge of the muscle.
Ken, I'm going to interrupt you because you actually mentioned a question. Our second question asked, what is the advantage of a 5-0 or 6-0 vicryl for plication and recession?
Well, for a full plication, for plications, I use a 6-0 vicryl because the knot's too big if you use 5-0. I like 5-0 on a recession. I like 5 on a recession because the knot is posterior and it won't be a problem, and 5-0 is stronger and lasts longer. I'm thinking about going to non-absorbable, but at this point don't really think I have to. I do go to non-absorbable on the superior inferior rectus because they tend to stretch. They tend to slip back. If you ask a hand surgeon, they think we're crazy using absorbable sutures. When a hand surgeon puts a tendon back onto a bone, they use non-absorbable. But I don't know if I went too fast there, but the vertical rectus, I use a non-absorbable 6-0 Vicryl. On recessions, I use 5-0 Vicryl, but you might want to think one day of going to non-absorbable. If you go to non-absorbable, you can use a 6-0 Vicryl. It's strong enough. Take the muscle off with the Westcott scissors. I always use the blunt Westcott scissors. And then if you have them, use locking forceps on the sclera. Here we can see this line is the insertion line on the sclera, and this is a locking forceps, and it identifies, this is when you do a recession, it identifies the insertion point. And here we can see there's 2 locking forceps on the insertion, and that's great. It controls, it's good for foreign excision, it's good for limbal incision. When you bring a needle to the sclera, keep the tip up. When an airplane lands, it doesn't land like this because it goes into the tarmac and it's no bueno. Okay. So when an airplane lands, it flares and comes down. So when you bring a needle in, keep the tip up, come down, and go in. And you can see in thin sclera, that's really important. And I'm going to show you a technique where you don't have to pass the needle back. It's a modified hangback, which I now use on most recessions.
So people are asking, here we go, about what kind of needle you use. So I think there's a few ways to answer this. One is what your slide shows here, and perhaps you can comment on the type of needle, depending on the suture.
So basically 2 needles. Well, there's a round needle, but other than a round needle, there's a side cutting needle, which we call spatula needle. And if you look at this diagram, especially this one, the bottom is flat. Can you see that, Ning?
Yes.
Can you see my pointer? Can you see the cursor?
Yes.
I can't. Okay. The bottom of the needle is flat, so it protects you from going into the eye. Now, a cutting needle, vertical cutting needle, the sharp part is pointing down. Can you see that here? I don't know if you can see it. The
Yep.
sharp part's pointing down. You use the cutting needle, you'll cut right in the eye. In fact, there was a case I did when I was very young, starting out, and they gave me vertical cutting needle. Guess what? On both passes, I went into the eye. And because I left the needles in and I came out, luckily it was only choroid came out. So this is a vertical cutting. You don't want that. Don't. You want is a flat bottom. And I like the flat bottom on the bottom like this. That's the Parks S29 needle. Looks just like that. And he has the flat part larger, so it helps protect the sclera. Is that clear, Eni?
Yeah, that's clear. I think some of it just depends on what you have available. So if you're using a 5-0 Vicryl, at least here in Canada, we only have the S14 needle, spatulated needle, which is the diagram you have on the left there. You get used to it. And I think the other really important part is it's a spatulated needle, but if you should wobble your needle and it turns 90 degrees, now you've converted it to a vertical needle and it's just as dangerous. So you have to really keep that needle flat.
Yes, that's a great point. You got to keep the needle flat. And the way you do that is you use a curved needle holder. It'll allow you to keep it flat. That's why the curved needle holder was developed. A lot of people don't realize that, but it lets you work in a hole and still keep the needle flat. So play with your curved needle holder and you'll see if you splay the needle out, you can actually lay it flat even in a hole. Resection is the only time I really clean back. I don't quote clean back because you don't need to remove intermuscular septum. This is intermuscular septum. The muscle is hooked, and you can see the small hooks are pulling up intermuscular septum. And this is from the surgical atlas, which is coming out in a couple of months. Oh, how did that come out? Oh, excuse me. But anyway, you can go ahead and remove it. If you remove intermuscular septum, cut close to muscle. Everybody's afraid of cutting muscle. If you nip the muscle a little bit, there's bleeding, but it's not the end of the world. Keep close to the muscle so you avoid getting in orbital fat. And here's the muscle sleeve that Parks calls the muscle sleeve, and it's been called the pulley, but it's where the muscle penetrates posterior tenons, and that keeps the fat backwards and keeps the fat out of the surgical field. Here we can see the pulley, or which Marshall Parks called the muscle sleeve. I still call it the muscle sleeve. And you can see the muscle going posteriorly, penetrating the sleeve. If you cut into that sleeve, fat will come out. And you say, well, so what? Who cares? I care, and you should care. So the function of Tenon's capsule is to keep the fat. Here's fat, and this is the Tenon's capsule. Here's the muscle. This is the eyeball sclera. If you violate this membrane that keeps the fat, orbital fat, back, the orbital fat now is exposed, and it can scar to the muscle, or it can scar to the sclera. Now you have a scar that goes from sclera, hold on, from sclera all the way to the bone. This is one of the most severe complications of strabismus surgery, because this scar is almost impossible to remove. You remove the scar, it comes back. And that's fat adherence, which the great late Marshall Parks identified, and he identified it when he was doing inferior oblique surgery and not being careful. So be very careful not to violate posterior tenons and expose orbital fat. If you do expose it, I try to close tenons over it with a 7/0 vicryl suture. And I just avoid that like the plague. So in a resection, I put a suture in the back here, and I do a double throw, and then I tie a knot over it. And then you pass your suture perpendicular to the muscle fibers, and I lock each side. And then we remove the muscle and advance it. I hardly ever do resections anymore. It's funny, I don't do these surgeries anymore. So now I do the plication, which I invented when I was very young. And you put your sutures back, you can do 3-point fixation, small little bite in the center, and then locking bites each edge of the muscle. You pass your needles through sclera. What's nice is that you're not removing tissue. You can't lose this muscle. I think I lost one in a resection, but I've seen a few of them where during the resection, because it's tight, they pull out and the muscle goes back, and it's a disaster. So I like this. Also, it's semi-reversible, and it preserves anterior segment circulation. Here I am a couple years ago in this photograph injecting fluorescein, and you can see the iris angiogram I had removed in this animal model, the medial, superior, and lateral, and just left the inferior, and I plicated it, and you can see it still has fluorescein flow to the anterior ciliary vessels. And you can see the fluorescein pattern here, and it's dark up above. By the way, over time, this got better, and it's rare that I've ever seen a persistent anterior segment ischemia, but this is nice as a vessel-sparing procedure if you want to make sure you avoid anterior segment ischemia. Semi-reversible, vessel-sparing, safe, no lost muscle, and the same surgical tables at the resection. People ask me that, and I used to say you had to do a little bit more with the plication, but other colleagues say no, dopey, just the same numbers as a resection.
And the same question, if you go back to the last slide, comes up often when we're teaching courses, and someone asked this in the polling Q&A. What happens to that bump? And so, that bump goes away after a few weeks, and it's really not cosmetically noticeable at all. So I always do warn patients, especially parents, if this is the second surgery, don't worry about the bump, it's going to go away. And when you go back for surgery, if you're reoperating on a previous plication, you don't see that bump. It's like nothing's really happened.
In fact, I've gone back on them, and I was surprised. It almost looks like a virgin muscle. It's crazy. I got to get going, I guess. All right, you can use betadine pre and post-op. I soak my sutures in betadine because it was the group in New Orleans, George Ellis and Sprague Eustace, who did a study, and they found that sutures at the end of strabismus surgery have bacteria. They cultured them out, and it was high percentage of sutures had bacteria. If you have bacteria in a foreign body, which a suture is, that's a real problem in regards to infection. So I soak my sutures in betadine. I close the conjunctival incisions. I was taught by the great Dr. Parks that with fornix surgery, you do not need to close them, but now you have an open wound, tears have bacteria, and it goes back. And he did have a couple endophthalmitises, at least one for sure, and one was bilateral. So he would put the patients on antibiotics. I don't put them on oral antibiotics. And in the last 10 years, when I put the sutures in betadine, I close my incisions, I use pre and post-op iodine. I haven't had a significant infection, knock on wood. I used to get a small infection in maybe 5% of the patients. Avoid stretch scar by avoiding corticosteroids. I do not use topical steroids. I remember when I told Dr. Ning Strube, you don't need topical steroids after strabismus surgery. She said, you're nuttier than a fruitcake. And I said,
Just to
try it.
clarify, that phrase never comes out of my mouth, but
I do exaggerate at times, but this is not exaggeration. Try not using corticosteroids. You won't have that stretch scar. Stretch scar means that after surgery, you don't get good healing and the muscle pulls back and you have an increased recession you don't want.
I listen to
Now,
you, Ken, and I haven't used steroids for probably 8 years, and my patients, they look great. They're just as comfortable. There's no difference
there's no
comfort-wise.
difference. And I didn't do a study because it's so obvious. A good colleague of mine from Caltech, a big university, he's a research guy. You know what he said to me, Ening? He says, if you need statistics to prove your point is weak. I love that. So this patient does not abduct the right eye. Do you see that, Ening? In this picture on the left with the circle, that right eye does not abduct. So I'm going to ask you, is this palsy, lateral rectus palsy, or is it medial rectus restriction? You don't know, do you?
Oh, you're asking me. I thought there was a poll coming up to ask everyone.
You're right. There's a poll question. How would you determine if this is a tight medial or a weak lateral? Everybody says forced ductions. You're all wrong. Sorry. That's why this is fundamentals. It's B and C. First of all, evaluate for saccade. Now watch my hands. If there is an abduction saccade, this side moves fast. You can't have a palsy. And forced duction doesn't tell you that. Forced ductions doesn't tell you if there's an abduction saccade. Forced ductions do not tell you if the muscle is strong. It just tells you if a muscle's tight. I never do forced ductions in the office. I do them under anesthesia. You can tell without forced ductions, and you can do the force generation test in adults. In kids, I do saccades. So let's see. Here's the same patient. And there it goes. Watch the right eye. Watch the right eye. No abduction saccade. It does. There it goes. I'm tired of this. There's no abduction saccade. It floats. And it even floats to midline because the medial relaxes on abduction, but there's no saccade. The lateral is weak. And let me prove it to you with the force generation test. And you need real high technology for this. You need a cotton tip applicator. And I put a drop of numbing medicine in the eye. And let's watch. This is super high tech. There's no abduction. You can feel the lateral is deader than a doornail. You see that? Ening, do you understand? You take the cotton tip and you push the eye in a little bit and you have them look the other side, and then you have them look against the cotton tip applicator. There's nothing. This is deader than a doornail. And I didn't do forced ductions. Forced ductions hurt. Now, at the time of surgery, I will do forced ductions because there often is a tight medial with a long-standing sixth nerve palsy. And here we see another sixth nerve palsy. This little child is looking to the side, has a cavernous sinus aneurysm, and they went to operate and they got a sixth nerve palsy. Now, what do you do if it's truly a palsy and this patient could not generate an abduction saccade, what do? You got to do a transposition. And the Hummelshine works, the Jensen works, just gets the viable tissue, viable muscle from the superior and inferior and move it over to the lateral. Now, when you move it over with a Hummelshine, you have to clean it way back 14 millimeters. Otherwise, it doesn't mobilize. Does that make sense, Ning? If you don't go all the way back, you don't mobilize it. So I help bring it over, and the right modification, which is nothing less than genius, is here. I suture it. I suture the transposed muscle to the lateral. I suture the inferior partial to the lateral. And I like the partial tendon transfer like Hummelshine and Jensen because you leave anterior ciliaries intact of the superior and inferior. And I have seen and I have heard of anterior segment ischemia with transposition because I also recess the medial. So for poor function lateral rectus, I transpose partial tendon and I also recess the medial because in virtually every case, the medial is tight. I don't use Botox because it wears off. And I remember I was at a meeting, they used Botox and they showed me a great result. And I said, what happened 6 months later? Well, the eye went back in because when the Botox wears off. So I don't do Botox in this situation. If you notice this patient after the right transposition and medial rectus recession, eye looks in good position, but here's the problem, and it happens in all these cases. They show you this nice photograph here with a girl in primary position, but when they look to the side, the eye doesn't abduct because the lateral's weak, and it really doesn't adduct well because you've tightened the lateral and you've weakened the medial. So these patients, the eye you operated, in this case, the left eye, will not abduct or adduct well, and the good eye does this. And I recently did this and beautiful result, and it was an older patient, long-standing sixth nerve palsy, not happy because she was used to a face turn, and now this eye's moving like this. Now here's a patient with a significant esotropia, and she has cerebral palsy, very nice lady. Does she have a palsy, or is this just a big, tight medial rectus? She had an abduction saccade. Now, no abduction. So some people tell me if it doesn't go past midline, it's a palsy. That's absolute bullcocky. You can have a tight medial so it doesn't go past midline. That doesn't mean it's a palsy. So I tried this patient with an OKN drum, and she had micro saccades, Ning, just boop, 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 boop. And I go, that lateral's working. And I put the cotton tip, and she had lateral rectus function. So what I did was an R&R because that was a blind eye. It's restriction. And I was at a big dog meeting, and some big dog from the university said, I did this transposition, but I saw in the pre-op video there was abduction saccade. So I raised my hand. I said, that wasn't a palsy. And thank God somebody in the crowd said, yes, it's not a palsy. You misdiagnosed it, dopey. I didn't say dopey, but I was thinking it. And now look at it. She's got full abduction, no transposition. Just recess the medial and tighten the lateral. Super happy.
The maximal amount of surgery, as you said earlier.
Yeah, I went over my own limits.
Yeah.
When the medial is so tight, and that's where the right groove hook works, when that tight medial. But look at that full abduction. Just to remind you, look at that. No abduction. It's a super tight medial.
Ken, I'm going to interrupt you for a minute. We're just a little behind, but I think it's really important. Someone's asking, how do you demonstrate an abduction saccade? So you're really just getting two targets, so like a finger and an instrument, or just even two fingers, and say, look here, and it's that quick ballistic movement to see if they can generate that saccade. Do you have anything you want to add, Ken?
Yeah, you can use an OKN drum, optokinetic drum, and you rotate the drum and it will induce nystagmus, which is nystagmus requires a good saccade. So this is, I'm running a little behind, so I can take over your time, Ning, don't worry about it.
We'll make it up. I'm not worried about that.
All right, so this patient has a face turn, and when you hold the head, you can see that the left eye is not abducting. And because this was long-standing with the face turn, it's probably Dwayne's 99% of the time. So this kid is like, I don't know, let's say 3 years old, and this has been there since infancy. And by the way, the better term here, it's a gaze preference. This patient has a right gaze preference, left face turn. So it's a Duane syndrome. Now, are you going to do a transposition? People do that. I don't. All I do is recess the medial. So here's the answer to your question. We'll ask it. What operation would you do for Duane's esotropia that you just saw? Full tendon vertical transfer to the lateral, partial tendon vertical rectus transfer to the lateral, medial rectus recession, and no surgery works. Forget about it. I recess the medial rectus. And the reason I recess the medial rectus is it's fast, easy, and you don't screw up. I love that. And I was taught that by David Guyton at Hopkins. That's where I did part of my fellowship was with Dave Guyton at Hopkins. And he just recessed the medial. And I was amazed how good the results are. So and the reason that the medial rectus recession works, it's not a true lateral rectus palsy because the lateral rectus is innervated partially by the third nerve. So it's not a dead lateral. A true sixth nerve palsy, the lateral is dead. In Duane's, the lateral is not dead. It has tonic tone, albeit from the third nerve. So you can just recess the medial. That's what I did here. And a good number for most Duane's is 6 millimeters. Now, I've heard, but I've never seen it, that you can get overcorrection. And I think those overcorrections are stretch scar because the medial is tight. And if you use steroids post-op, and that's from Irene Ludwig and her AOS thesis, that the muscle can pull back when it's tight. I don't use corticosteroids topically or orally or any way. I know people inject steroids, don't do that. So this patient came to me with a small right hyper of 1 to 2 prism diopters, and he was sent by the refractive surgeon who just did refractive surgery for myopia and astigmatism. What do you think? 1 to 2 prism diopters of a hyper which increases in down gaze. So he's got a right hyper increasing in down gaze. If I weaken the left inferior rectus just a little bit, I could bring this eye up. And actually, if I weaken the inferior rectus, it works more in down gaze. It should correct it. So I'm explaining to this guy that I had a dream about just cutting the tendon. And here it is. You just cut the tendon a little bit awake just with topical anesthesia. And that should weaken it. So I sat him down. I had a fellow from Saudi Arabia who thought I was crazy telling the patient that I had a dream. I never did the surgery before. And I'll show you my very first central tenotomy, the right central tenotomy, left inferior rectus muscle. And here it is. You got it. I'm just going to cut the tendon. I have grasped it with a 0.5 forceps, toothed forceps. And I'm going to laugh. I'm going to laugh at this. Watch. I'm laughing. So I just grab the muscle with a 0.5 tooth forceps, pick the tendon up and cut in the middle. Sometimes it bleeds, but the ciliary vessels are on the side of the muscle. So it usually, you won't get bleeding. And here's an ophthalmologist, a friend of mine, and he had double vision after retina surgery. And I did the right inferior rectus to bring it up and the left superior rectus. You get about 1 or 2 prism diopters. It doesn't correct more than 1 or 2 prism diopters. So you can do 1 vertical in one side and 1 on the other. It really doesn't work for esotropia or exotropia, just micro verticals. And he finally was happy. And we had him over to dinner and he was doing great long term. Now, what if the vertical is larger? Here's a right hyper of 6, which increases in up gaze. So what would you do for this patient? You've got a right hyper increases in up gaze. You can't make this one go faster, but you can stop this one from overshooting. So how would you stop? He's got a right hyper increasing in up gaze. How would you stop the right eye from overshooting? You can do a right superior rectus. This is one of our polling questions. You could do a right superior rectus, right inferior rectus tightening. So you can weaken the superior on the right. You can tighten it. You can do the left inferior rectus. That would bring it up, or A and B. And remember, the right eye is overshooting. So how would you stop the overshooting? Well, you could do which ones? Yeah, you can do A and B. Exactly right. You guys are smart. That is so true. You could do A or B.
Yeah, and I think to clarify, it's A or B, not doing both at the same time for such a small deviation.
Thank you, Ning. I need you because, yeah, I mean, either one, A or B. I said A and B, but A and B is the correct answer, but it's not to do them at the same time. Thank you, Ning. Very good. And so on deviations larger than 1 or 2 prism diopters of vertical, and we can do the central plication. And basically you put a suture in the back of the muscle and then you can anchor it in front and you plicate it, but you're just plicating the center. And it's about 3 millimeters. I use 6.0. Vicryl, and now I've switched to 6.0 Mersaline. So I use 6.0 Mersaline. This is older Vicryl. This is a fully awake patient. I've done these awake. I can do them with just laryngeal mask anesthesia. This is a fully awake patient. Let's see. You put in topical anesthesia, and then you make a swan incision over the rectus insertion. Your incision goes over the tendon, and you have the patient look up. Now you put in a traction suture right in front of the muscle, and that's where the sclera is thick. And so even if you go deep, that's where they do injections for macular degeneration, not a problem. And you pull the muscle, pull the eyeball up, exposed posteriorly. In older patients, there's not much tenon. You can just pull it back. In younger patients, you have to remove tenons, and you grab the center of the muscle with a 0.5 forceps and pass your suture under your forceps. And in this case, you do a whip tie. You do 2 passes. I'm not going to show it, but you do 2 passes and then tie a knot, simple overhand knot. And then you can pull the central muscle up to the sclera. So your traction suture is the same suture you use to secure the muscle. Ning, you're going to be showing this later. For horizontal deviations, you get 6 to 8. Don't hesitate per plication. So if we have a 16 prism diopter, esotropia, you can do bilateral, lateral rectus, central plications of 5 millimeters. Standard plication is 5 millimeters. Vertically, you get a little less, 5 to 6 prism diopters for a 5 millimeter central plication, and Ning's going to be showing it. I like this procedure a lot for older patients with adult divergence insufficiency esotropia, which we see a lot of nowadays. You can do bilateral medial rectus recessions, but if the deviation is small, in this patient only 12 prism diopters, it's perfect for central plication. If the deviation is over 18 or 20 prism diopters, I do bimedial recessions, and they're amazing. Do more surgery than you think you need, and we get over 90% success rate with either plication or medial rectus recession. But if they measure 12, I'll operate for 18 to 20. Now, how about thin sclera? I'm almost done, Eni, don't worry. How about thin sclera? Who loves passing your suture through thin sclera when you know retina is right behind you? I cry. Here's a super high myope with laser and had retinal detachment surgery and had strabismus. So I recessed the superior rectus for double vision after retinal surgery, super thin sclera. I thought everything went great. And then he said he saw a worm. And what he was seeing was my suture, which untied, and it was Mersaline, and went into the vitreous. I said, holy cow. So I dusted off my indirect and I looked back and I saw this little worm, and that's my Mersaline suture. I sent it to the retina specialist, and they said, oh, Ken, I'm so happy. I got a picture of it. I said, my God, destroy that picture. I don't want the lawyers getting ahead. Anyway, they didn't do anything. They left it there, and it's sort of scarred down, and nobody did anything. But my point is, anybody can get in the eyeball with very thin sclera. And so that's why people do hangback. But hangback, I used to do all the time for adjustable sutures. I used to hang it back. I don't do adjustables anymore. But hangback's not stable. Dave Guyton and Chung reported that almost 20% will have, on medial rectus, will have overcorrection over time. And I found it for exotropia, you can't push the muscle back far enough. It won't go. So I don't like hangback. That's my hang up with hangback. And the knot's in the front, which can be irritating and you have to remove it. So I don't like hangback. So I did a new hangback. I pass my needle once you secure the muscle parallel to the insertion, and then I hang it back. And I put my knot posterior where the muscle is, so it's not in the front, and this is flat. And here we can see the knot in the back. And this short video. Now, in order to keep it there so it doesn't move around, I put fibrin glue. I first tried cyanoacrylate, and I published it doesn't work because in 50% of the cases, the glue extrudes, which is horrible. So I use fibrin glue. And I put the fibrin glue over the muscle, and that secures it. Now, to seal is what I use. I don't know what they have around the world, but it's fibrin glue. And so you can see the glue here over the muscle and sutures. I put it over the muscles and sutures, and you just hold it there in this position for 30 seconds. And then you let it go. What I also do now is I do limbal surgery, and I don't even need sutures some of the time, and you just push it back and the glue holds the conjunctiva in place. And here's a patient with a large esotropia, high myope. You need to do large medial rectus recession, 7 millimeters bilateral, and I did hangback glue. And the glue holds the muscle in place. It dissolves after about a week, but by that time the muscle's secure. So I like hangback glue. And we published our results. Hangback glue, 94%. Standard surgery, virtually 90%. The same, but you don't have to pass your needles through thin sclera. And then I started this on just the high myopes, and now I use it on everybody because now I can do this surgery. So my conclusion is, with hangback glue, even Wright can continue to perform strabismus surgery. Thank you, guys. I look forward to Ning's live. She's going to do live surgery, and it's going to be fun. So hang in there.
Thank you so
And
much,
I'm
Ken.
done. Oh, this is my family. A couple of years ago, and here's Andrew here, this big guy with the beard. I operated on him when he was 5.5 months old, and he's still straight, thank God. And I don't know if this is going to work. It's not good. It's not going to work. That's good. It's just my house. This is where I'm right in my house right now, eating. I'm in that house right now. I'm up there in the right upper part there. And this is my home in Redondo Beach, California. And if you're in Redondo, come visit me. We'll go surf. I don't surf that well anymore, but I can still surf somewhat. Thank you, guys.
So here we have our patient, and let's say he has a lateral rectus muscle that needs to be recessed. So I'm going to demonstrate that. Ken and I do both limbal and fornix incision. I'm going to describe the limbal incision. Your terminology, just make sure you don't call it a limbal-based incision. That's the glaucoma terminology. We don't use that. It means something different. Typically, we'd put in an eyelid speculum, but just for the demo, for ease, I will leave that out. So typically to move the eye into position, we'll use a curved locking forceps of some type. Now, if it's an adult with very friable conj, you may just use a Q-tip to bring the eye into the position that you want. But this is a young patient we have here. So you'll do that. Again, take that out just because for this model, that's not necessary to keep it there. And then very importantly, as many of you know, we're just going to go from basics. Some of this will be obvious to the experienced people in the crowd, but you want to make sure they hand you a blunt Westcott scissors. The last thing you want to do is pierce the eye with sharp Westcotts. I'm going to try and zoom the view. It wants to go back to unzoomed, so hopefully you guys can see this here.
It looks great, by the way.
Good. So I grabbed the wrong force up. So you want to grab this is a 0.5 non-locking. So here I'm going to create my wing incision. I'm doing a limbal recession, limbal incision really for any surgery. And I'll extend that wing incision towards the limbus. Now, this eye is non-vascular. It's a silicone model, but you sometimes can't get right to the limbus. So there's our first incision. And then what you need to do, depending especially on the age of the patient, is you want to dissect into this quadrant. Sorry, it keeps bouncing. To remove any of that Tenon's tissue. So we'll grab at the apex here, dissect into that quadrant until you can get down to that bare sclera that Dr. Wright was describing. This is really important, and I tell all my trainees this same thing that Dr. Wright taught me years ago. The best way to go fast is go slow. So make each of your movements purposeful, and the surgery will go well and also efficiently. So what you want to do here, for the ease of the model, I just need to loosen up the muscle here. So give me a second. So you're going to use this small hook, as Ken demonstrated, maintaining contact with the sclera, go down into that quadrant, and then make a turn. Based on the spiral of Thielow where that muscle is going to be. So you don't need to go too far back, but back enough to get in under the muscle. So now that muscle is hooked. I like to use the Jamison hook, but you can use right hook, whatever hook you have that's longer and has something on the end to prevent the muscle from slipping off. Same thing, you want to go contact straight with sclera and go behind your small muscle hook.
Notice she's perpendicular when you start. That is so, Marshall Parks told me that many years ago, and it's so critical. It makes it so easy to hook the muscle.
So here I haven't moved, really just doesn't want to zoom. So use your imagination if you can't see it clearly.
We can see it. We can see it very well.
Okay.
Yeah.
See how you can see the tip of my Jamison hook there? So that tells me that I've likely hooked the whole muscle. And you just want to be careful, especially if it's a non-re-op. You shouldn't be jamming that muscle underneath. If you are, you're going to hit the muscle. You're going to get bleeding from contusing the muscle. So try to avoid that and be gentle. Okay, so I have my muscle now. So if I had my curve locking here, you can remove it because now your Jamison hook is supporting the eye. You'll use your Westcott scissors again to blunt dissect underneath the conjunctiva and remove any of that anterior tenons. Again, in an adult, there's going to be minimal tissue there. And then with one tine of the scissors under the conjunctiva, you'll make a nice conjunctival peritomy as close as possible to the cornea. And then I like to make my second wing incision a little bit smaller. For this demonstration, I'll make it bigger just so you can see. But just so then when you're closing your conjunctiva, you don't need to do as much suturing. So here we have our muscle. We'll just tuck that conj back.
It looks great, Ning.
You can see it okay?
It looks super good.
Okay, so hopefully there's no questions there. This is pretty straightforward. A little different from how I was taught as a resident to make my wing incision and then my second wing incision. It was sort of a lot of back and forth. So I like this technique. Now I teach medical students and residents, first time they're in the OR. I love this right hook. I use it even if I have no residents because it gives me that extra security of not potentially hitting the sclera and having a bad outcome.
Also, it pulls the muscle into the surgical field, where if you just have the Jamison hook, it pulls it away from the surgical field. So you'll see when she takes out the Jamison hook, now you can pull that muscle right in nasally. You can pull it nasally right into the surgical field.
So can you guys see that? So I replaced my Jamison hook with the right hook. And what Ken's saying, it's long enough so that it keeps the muscle nicely retracted and that muscle nicely sort of spread out on the hook for suturing. So I'm going to get my suture. Now, someone had asked, I think we addressed it, what different types of suture material can you use? I'm going to use a 5.0. I only have access to the S14 for the 5.0. I get used to it. I would just say if you're using lots of different sutures, make sure you know what needle you're using because the S29 is slightly smaller and has a different feel. So as long as you know what you're using, then you'll be safe. So we use a double-armed vicryl suture, spatulated needle. And as Dr. Wright mentioned, I do the same thing. I have my OR team soak the sutures in a 50-50 solution of the povidone. So it ends up being about a 5% solution. So they get a bowl, put the regular scrub betadine that you'd use for the face in the bowl, and then dilute it with sterile saline. And then we'll soak the sutures in that to prevent infection. All right, so here is my needle, and I don't know if you can see that. And again, I'm holding the needle with this curved needle driver. As you can see here, this always trips up the residents if they're first starting. The curved needle driver's going this way and the needle's coming out, all right? And that allows me to operate in this small space without having to worry about hitting, the forehead or the nose. And you want to also make sure that you're holding your needle, I don't know if this projects well, but on the flat part of the needle. If you grasp the needle on this rounded part, the swage, your needle is going to wobble, and that's very dangerous for all parts of surgery, but especially the scleral pass. Okay, so here we go. We're going to do our central security knot. So it's full thickness, a few millimeters in the center. I try never to grab the end of the needle because that will dull the needle, and you want it to be as sharp as possible for your scleral pass. So I'm doing this without an assistant. I'd say 95% of the demo is fine without an assistant. And every once in a while, I wish Dr. Wright was here with me to hold an instrument. But I was going to ask Sean, but he's not really
Do
interested.
you make a double pass there, Eni?
I don't know. I just did a single pass.
So I do a double pass, and I'll tell you why.
Okay.
What's
You
the
also do
difference?
a cinch, which sometimes.
What's right? What's the difference between a cinch and a knot? I'll let, if you don't mind. So a cinch, when you double pass, it's like the first thing you do when you overhand knot when you tie your shoe. The more you pull, that tightens. But once you lock down a square knot, that diameter sticks, and so the muscle can pull.
Do
So
you want
with
me
a
to show that? You want me to go
double
back and
stroke,
show that cinch?
no, it's
Okay.
fine.
If we have time,
So
we'll go
if
back and show another one. So this is just
so,
a straightforward, regular knot that Ken is describing that creates that fixed circle. I'll show a cinch later if you want to add
yeah, we can do.
fine tune it.
Your locking bites will be a cinch, Eni.
True. So here we are. All right. So we've put in our central security knot. Now you want your sutures to be as close as possible to the insertion. So again, this is a model eye, so it's going to appear like there's a lot of tissue between the insertion and the knot. In real life, it's not that large. I'm going to go anterior here, and this step, as you may know, is a partial thickness. You're weaving that suture all the way through just to get to the end. Didn't get all the way to the end, but close enough. And we're pulling it through. And then here I'm going to reload my needle and do a full thickness bite. These are the most important steps when you're securing a muscle, whether it's for application, resection, recession. That needs to be a good bite, a few millimeters, I say 2 to 3 millimeters, full thickness. And here's the key part that Dr. Wright was mentioning. You want to make sure this is a locking bite. So I've purposely left, hopefully you can see here, there's this sort of figure 8 shape here. That's going to allow this to be a locking bite. So I'm coming here. Can you guys see that? So I've looped my suture through, it's twisted, and I'm going to use one tine of this needle driver to lift up so you don't create what's called an air knot. So that's going to be nice and tight at the pole of the muscle. And when I let
Yeah,
go of it, it doesn't
you can see it
unravel.
very, you can see it
You guys
very
see that?
well.
Good.
You can see it very well.
So then you repeat the same thing on the other side. And, I use my right hand and left hand pretty interchangeably. You can do forehand, backhand, whatever makes the most sense for ease of access to the muscle.
Hey, Ening, why don't we do a hangback my configuration?
Sure.
You can just put the needle back like you're going to pass it posteriorly, but let's let's show
Okay,
the
that's a
newer
good idea. So
technique.
someone asked on the question, do you use loops or an operating microscope? Um, and I think I answered it. At this time, I do what I'm doing now. I just wear a pair of glasses. Um, if I have to record for a meeting, I'll try and use the microscope, but it's not in my habit to do so. I don't know, Ken, if you want to comment on that.
Yeah, I've used the microscope a few times and I don't like it because it restricts your view. You can't see. I like to see where the assistant's hands are. See,
Yeah,
you can
that's
actually see with this view you have here, anything is zoomed out, but you still see there, you see everything very well,
yeah.
and this is all in proportion.
Here's that
And also
loop.
the other problem is that your depth of focus is very finite, very small with a microscope, and your depth of focus with reading glasses is very good. So I just use reading glasses.
Yeah, I do the same. To be fair, I do make my residents wear loops because I want them to see everything in detail until they're comfortable with the anatomy, etc. Okay, so here we have our, I've got my hook, I've got my sutures, they're on tension here. Not so much of an issue. If you've left some space, if there's no hook there, sometimes you could potentially cut off the sutures. You don't want to do that. We'll use our blunt Westcotts. Make sure, now here I'm going to exaggerate. If I pull up super tight, see how it's tenting the muscle? Someone asked a question, how do you prevent snapping a muscle or losing a muscle? So I don't have time to address all of the points for that. But here, if I should, cut, you can see how I could potentially go through sclera, especially if it's a tight muscle, thyroid, what have you. So here you want your scissors to go nice and smooth. I tell my residents, and I've already cut a little bit, you should never be jamming. If your scissors are jamming some tissue, that means you're hitting the hook or the muscle. So I'll disinsert one half, and then I'll use a 0.5 locking. This is a 3-2 to mark the insertion. And then you're going to disinsert the other end.
Meaning those are 3-2. I designed those at 3-2 because the storts are 1-2. If you have 2-3 teeth,
Oh,
you
did
have
I say two,
more.
three?
Yeah, no, they're 2-3. So you
Oh,
have
these are
you
two,
have a
three.
broader pickup and they don't come off. The 1-2 storts often come off the sclera because there's only one tooth and there's two teeth. This is two teeth and three teeth, so it's more surface area to grab the sclera.
So I don't do this in real life. Obviously, tissue is gold, but I'm just cutting off the conch just for demonstration purposes so you guys can see what I'm doing. Okay, so as Dr. Wright said, so what you need to do here is secure the poles of your muscle for the next step of your recession. Now, Ken wants me to demonstrate the hang
Just
back.
show how you would do a posterior pass.
Yeah. So I'm going to show a regular pass and then I'm going to take it out and we'll demonstrate the rest. So again, I'm just going to take these out so you can see a little clearly here. But you're going to use those 0.5 forceps to move the eye into the location you want and to support the eye. The most important thing, well, many important points, but when you're passing through sclera, you want that eye to be somewhat proptost and stable. So you always want to have one finger somewhere stable on the patient, like not on the tube or something that could potentially move. So should the patient move, you're moving with them and the needle's not going into the eye. So here I've got a caliper. If you're doing a traditional recession, you're going to, now, of course, this insertion looks pretty ratty. I'd not leave that in real life. You're going to mark here and mark on the sclera. And then here's my needle. I'm just going to make sure I'm not hitting anything. So if I'm hitting the forehead or if I'm hitting the lid speculum, I'll move things out of the way so that I can make a nice safe scleral pass. And here I'm going to splay my needle. Can you guys see that? The angle is more obtuse so that I can get up nice and high without hitting anything. So here we go. Let's say that's my mark. You want to have your tip up and you get that initial purchase. And you want it to be a nice thin pass and long enough until you can't really go any further. And see how my tip has kind of come out? Now it bounced back a bit because I'm in a sort of awkward position with this camera, but when I
Looks great.
re-grab, you see how I tipped it up? When you re-grab, you want to think about tipping up. This is a mistake I often see. The residents will make a scleral pass. They're like, oh, thank God I didn't pierce the eye. And then they re-grab and go like that. And then I lose some sleep or hairs or whatever. So you want to push it through. And then you're going to pull that suture through, and you'll do that on both sides. And that's your traditional recession, and then tie it down. Did you want me to do the whole thing and then take it
No,
out?
no,
Or,
that's fine. That's
all
fine.
right. So you
So
guys
I
understand?
don't, yeah, I don't like passing through thin sclera, especially over retina. So I now do hangback glue, and Enid's going to show you where you pass for hangback glue.
So this would be more like, I guess, a traditional hangback in some ways, that you're putting your scleral sutures anterior. And as you may know, you can and need to go deeper, both to keep it secure and also because the sclera there is thicker. So it's not that 0.3 millimeters behind the insertion, posterior to the insertion.
Actually,
Here,
Enid, I do the same depth pass because you're not on any more tension. In fact, the glue
true
helps
enough.
it.
True enough. For a resection or application, though, you'd want to go a little bit deeper, no?
Yes, for the plication, yeah.
So I guess I tend to do it similar. Good point. All right, so here I am. I've unlocked my needle driver. I've got my locking forceps here, and I'm just going to reposition my needle.
And it's much easier to pass the scleral pass in front of the insertion. And if you go too deep, you're over pars plana. There's no retina.
So if this isn't an adult, it's sometimes easier because there's not much tenons. If there is a lot of tenon, just make sure you clear that off so that you can get your sutures in well, just like usual. Make sure there's no blood vessels that are in your way about to bleed. And so here we'll make a really long pass. You can always see I'm
And
sort of the tip of my
I,
needle there. Hopefully you can see that. And I'm going to come out.
I
Now,
double pass that,
yeah,
Enid.
so I can't get across. This is, let's say this muscle is really wide, a broad
10
insert.
millimeters. By the way,
Yeah.
that's a number you should know. The insertion is 10 millimeters wide.
So I'm twisted on my camera here. I'm just going to say sometimes operating with the camera is harder than operating in real life. So
You're
uh,
doing great, Enid.
no
Super
judgment
good.
here. All
That's
right.
why I have you do this. Enid can operate much better than me, so I let her do it.
So thanks, Ken. So see how I haven't gotten quite to the other end. So then what we'll do here, either you can put it more centrally and just do one really long pass, but what I'll do, and obviously as Ken is saying he does, you just extend it. So you'll do them in parallel, in sequence, I guess is what it would be called. Parallel and in sequence. So again, trying not to grab the needle tip and then pull it through. So now you've done this super long pass anteriorly. I'm going to take these 0.5s off. Now just remember, I always tell the residents, they're sharp, so you don't want your suture to rub against them as you're doing this step because it'll fray the suture and then your suture will be weak. So normally in a hangback, for those of you who do hangback, you'd put your knot up here. But what we do here is suture or make the knot rather at the muscle. Now, this is where sometimes you need an additional help. So what I do is, let's say I want this distance of a recession, and I say, okay, my muscle is at the right position here, and I'm happy it's at the right position here. Then what I'll do, if I just tighten this up, it's going to shorten this end. So I'll get my assistant, being me right now, to hold the knot with the needle driver so that it doesn't tighten up. Does that make sense? Otherwise, one end's going to tighten up and your hangback will be a lot uh, less back than you wanted.
That's a
Ken,
good point, Enid, that you can grab the knot to secure that location
yeah.
and then tie over it.
Now you don't always have to do that, but sometimes if it wants. So there we go, and it's going to undo it. There we go. And I'll do it again, but just to demonstrate. So now your knot is back here. There's, it's not going to come through your incision. Can you guys see that?
That looks good. So
So that
there's
would
and then you
be
Then you
That would
put
be
your
the
glue,
hangback. Yeah.
right? And then you put your glue over that.
So we'll place a few drops of glue. Uh, really, for any of you who've used the to seal, it kind of spreads everywhere. We use it, the two drops separately, not all in once. So we'll put one drop, at least that's what I do here in Kingston. I'll put one drop sort of over the suture, one drop over the suture. It tends to spread here. And then I'll put the second drop and then I'll look at the clock for a minute and just let it sit. And then we'll pull the conj over top. And most of the time the conj kind of is adherent with just the glue, but then we'll add the 6-0 plain gut or what have you for just extra sutures for tacking it down.
Super nice.
Yeah. Okay. So what would you like me to do next, Ken?
Let's
The
do
plication?
central plication. The full plication is just the resection without removing the muscle. So I think that's pretty much known, but I think the central plication it's a helpful procedure for small deviations. Again, with the horizontal,
Yeah.
you get 6 to 8 prism diopters for the plication.
For the central plication, I will use a 6-0 suture. Let's see if I have one here. It doesn't really need to be double armed, but this is what I'm using right now. Now, this happens to be a 6-214 because that's what I have in my sim kit.
Eating, I'm using 6-0 Merceline now on the
Great,
central
you said that.
plication.
So if I have time, I can show you guys what we like to do if we're using a non-absorbable suture to be sure that that's extra important, that the knot and the little ends of the sutures don't come through the conjunctiva, right? Because by definition, the suture's there for life. All right, so let's say we're doing an inferior rectus central plication. Somebody, while I'm getting this set up, Ken, somebody asked a question. Have you gone back to resect a previously plicated muscle? And do you have any guidance as to the numbers you would use? I know the answer, but do you want to address that?
I've gone back on previously plicated muscles, and it's just like a standard re-op. The only thing which I remember was that it was amazing. The muscle did not looked in very good shape. So I'm not sure how would you respond, Eni?
I tend to use the same surgical tables as well, as if it was a muscle that hadn't been operated on. But obviously, as you do for really all strabismus patients, I say, this is a reoperation, it's less predictable. So here we have a right eye. We're going to do a central plication of the inferior rectus muscle. That's going to limit the superduction of the right eye, as Ken, I think, described in one of his cases. So I'll make the incision just anterior to the insertion here. So I'm going to grab the conjunctiva and make a small cut here. And then so-called smile incision. I guess it's like a modified swan. Now, if this is an adult, it's really easy in the sense that there's almost no tenons. If I'm doing this in a child, you're going to want to do that same blunt dissection right over the belly of the muscle, not like this. You want to be right over the belly. And then also here, importantly, because this is where your scleral pass will be, you want to dissect anteriorly to get rid of any of that anterior tenons.
I like that smile incision where the center of the conjunctiva at the center of the muscle is more towards the limbus, so that when you cover the suture.
Right. I know you've gone back and forth doing it in different locations and modified.
Yeah.
That's
You can
the
do
thing with Ken. If you look at a book from 20 years ago, I don't think you're doing anything that's in that book. So I always warn the residents, just because it's in a book doesn't mean the person who wrote it is still doing that technique. All right, so here I have the a 0.5 forcep, and I'm going to grab the tendon of the muscle. And if the patient's awake, you can move the eye, but I'm doing it in my asleep patient. And here I'm using my 6-0 to do a small scleral pass just anteriorly, and I will
And I
do.
agree. I agree. You should do that deep, fairly deep here to really secure it. Don't you? That's what you were saying. Is that right,
Yeah,
Eni?
yeah. Um, So here, this is now going to be used as your traction suture. So I will have my assistant pull the eye up and just put their finger down to keep the eye in position. And especially if the patient's awake, this is crucial because you don't want to be tugging on the muscle. So now pretend these sutures are pulling that eye up in this model. And in Dr. Wright's original publication with Dr. Leaner, correct? It was 5 millimeters posterior to the insertion, sort of empiric to have an effect of about 6 to 8 prism diopters. So that's typically what we do. But once you get used to your effect in your hands, you can, if you want to make it a little bit smaller, a little bit larger, you can go a little further back or a little more forward. So what I mean by that here is, here's my caliper at 5, and you're going to measure 5 millimeters. Can you see that? 5 millimeters posterior to the insertion. I'm just going to get that conj out of the way here. And I'm going to grab the center part of the muscle, just like that. So that's 5 millimeters back. Okay. So I have one end of my suture. I'm going to suture the center third of the muscle. So here I am going just under
You got it.
pardon me?
No, it's paused for a second, but you're good. You're good.
Oh, okay. Um, yeah, just interrupt me if it does that. I can't see both screens at the same time. So here we go. Sorry about that. All right.
That's where I do a double pass, Ening.
All right, let me show. You want me to do the double pass?
Yeah.
All right.
That way it's cinched
Yeah.
and you really secure the muscle so it won't slip.
So I'm just taking this conj out of the way. In real life, it's not an issue, but in the model, I'm going to cut it away.
Yeah. Don't do this. Don't
Yeah.
cut it.
And I mean, when you're practicing on your own, you don't need to cut it away, but just for the video purposes, it'll be easier to see without that there.
Yeah,
Okay.
that rubber rebounds. So
Okay. So what Ken's saying is I've put one, I don't know if you can see that. See how I've gone once? So what Ken's saying he wants to do is go back again. Hopefully I'm going to demonstrate this accurately. There we go. See that? So that's the cinch part. Well, the first part of the cinch. And then to tie that down, my suture's a little small here, but I'm going to demonstrate it here. I've got my loop. You're going to do one single pass with the loop and then tie that down. And that's really going to prevent it just being the simple 2 singles that could potentially unravel. So that's nice and tight there. And I'm holding on to that loop still. I'm going to do a second one. Now, when you soak the sutures in the iodine, they get a little bit so-called wiry, just a little bit, and I'm totally used to it. But just if you're doing that as a new addition to what you normally do, just be aware of that. So now we have can you guys see that? The muscle secured with that cinch knot. Centrally, it's 5 millimeters. Posterior, it's 1/3 of that muscle belly. And then really simply, you're going to attach these 2 sutures and that center part of the muscle is going to come forward. Now, this is the part where, especially in the model, I need an assistant, which I don't have right now. So I'm just going to demonstrate this, but it's hard for the muscle to come up again just because the silicone's kind of elastic. It wants to stay back. But let's see if I can demonstrate this. Now, when you're doing a plication, a full plication especially, see how I moved the eye from being superducted back down a little bit? Because you don't want your assistant or your traction sutures to be pulling the eye in the opposite direction, or rather in the same direction as what you're trying to pull the muscle, because now you're just fighting against each other. So I'm putting the eye, I'm giving it a little bit of slack. And here, I'm going to tighten this. It might pop out because I don't have an assistant. But see how that's going to come up? So I'm just going to leave it at that, because usually I'd have in a model, I'd have an assistant hold on to that knot, kind of like I did for the hang back. But basically what happens is this center part comes forward. Here's my forceps. This center part comes forward like that, and it kind of looks like that. It doesn't look like a nice taco like when you're folding for a full plication. It's just the center part, and then I'll bring the conjunctiva forward, and I'll be very careful that I've closed my conjunctiva so that it's overlying the muscle, and I'll bury my sutures for comfort for the patients as well.
Very good. Good job, Ning. It looks super good.
So there was a question. How are we for time? There was a
We're good.
question in the, oh, there's 26 questions. Okay. There was a question about plications, and I want to bring it up because I'm just demonstrating that. Tulin, sorry, I'm going to say your name wrong. Tulin mentioned, I applied central plication to a patient at the same time I applied recession to the antagonist. However, I opened it up a week after due to overcorrection. I saw that the muscle fibers in the central plication area were torn and the plication lost its effect. What do you think? I don't know if you have any suggestions or comments, Ken, about that. I have not had to go back for a central plication. So I mean, I have gone back to repeat it like months later, and the muscle just looks the same. For a full plication, for both, when I'm undoing them, you want to undo it within the first few days because otherwise it tacks down very securely. So I've seen it not come undone. I don't know if you've seen this example, Ken.
Yeah, if you cut the suture 1 to 2 days after you plicate, it will reverse. But then I cut it at 5 to 7 days and it hardly moves. So by 5 to 7 days, in my experience, it sticks down. But
Yeah.
again, I don't use steroids, and then maybe if you use steroids, it won't heal so rapidly. But in my experience, if you cut the suture after 5 to 7 days, it really doesn't relax very much.
So maybe I'll quickly show the central tenotomy since that takes in real life and in demonstration about 30 seconds. Um, so this is a procedure that you can do easily in the surgical suite with the patient awake. Of course, pending picking a patient who doesn't mind things coming near their eye. You'll freeze the eye, numb it with proparacaine, tetracaine, whatever you're using. Know approximately the distance of the muscle, so you don't need to necessarily measure it because you can visualize those ciliary arteries. And in an awake patient, you'll tell them, look down, please, Mr. Model. And you're going to grab that tendon and you'll be able to move the eye. And you should be able to move the eye. If the whole eye doesn't move, you've only got conjunctiva superficially. So you're grabbing through conjunctiva and tendon. And if the patient's awake, they'll say, yeah, I see things moving. And then again, can't emphasize enough with your blunt Westcott's. Oh, we'll use a drop.
Inning,
Yep.
I do it the other way. I cut underneath my forceps.
Yeah, I know I'm doing it left-handed. Let me do it here. Thank you. I knew it felt awkward. Okay. So, and I forgot to mention, really important to put a drop of phenylephrine, 2.5% to try and blanch the vessels and try and limit bleeding. In a patient, I do warn patients that once in a while, even if you're careful to avoid those ciliary arteries, you might have a bleeder, just put some pressure on. It's going to have the same effect. It just doesn't look as nice. So here we are. I'm grabbing the tendon exactly as Ken corrected me. Here's my scissors. And you've avoided those ciliary arteries on either side. And you're going to make a small snip.
Yeah, I actually go tip up, but with the scissors. I can't tell. Yeah,
Yeah.
exactly. I couldn't tell.
Yeah, I do tip down, but I think if you're careful, it probably doesn't make a big difference. Now here, I wasn't deep enough. So here I am, tip up. It's probably going to be better. And I'm going to open it up a little bit. And that's all it is. You don't need to close the conjunctiva. Now, what's nice, if the patient's awake, you sit them up, do your cover test, have them look at the target that they were looking at preoperatively, and they may say to you, oh yeah, it's closer. Oh, it's single now. Or, they'll say, oh, there's just a little bit. And then you can bring them back, lie them back down and say, okay, let's do a little bit more. You really can't overcorrect unless you're completely cavalier, and then you'll make another little cut and then sit them up and that's usually good. And I've had a handful of patients. My patients in general in Kingston aren't that interested in awake surgery of any type, but the few that I have done awake will do one or two snips, and then they'll come back maybe a year later and say, it's drifted a little bit, and you can easily repeat it. So this is a almost risk-free surgery.
Yeah, and then I'll consent them for both eyes.
Oh,
So
right.
like you just did the right superior rectus, and if
Yeah.
that's not enough, I'll do the left inferior rectus to bring that one up. And it's interesting. You can get a little bit more by cutting, but you don't want to cut the muscle off. So
No.
just cut the central muscle. And I would do no more than 5 millimeters of central tenotomy. Now the muscle is 10 millimeters wide, so I'd cut the central five. And the more you cut, the more you get close to the ciliary vessels. The ciliary vessels are on the uh, uh, sides of the muscle, not in the center. So if you do a central tenotomy, you get less bleeding. But when you extend that tenotomy, you can cut an anterior ciliary vessel, and then just take, as Dr. Strube said, um, the phenylephrine 2.5%. Don't use 10%. It's if you don't know, use 2.5%. You don't want to have a cardiac arrhythmia. So use 2.5% phenylephrine on a cotton tip, not a Wexel, because it doesn't give you pressure, and put direct pressure over the ciliary vessel for 2 minutes on the clock. And it's the longest 2 minutes in surgery because you got to sit there for 2 minutes. But if you put phenylephrine on a cotton tip applicator, put direct pressure, and then on the clock, you have an assistant look at the clock and wait for 2 minutes with the pressure. It will stop. I do not use cautery.
So, I had a lot of questions about using the central tenotomy for patients with a small esophoria, and your study can show that it's really not very successful for ET surgery, probably because of a large underlying esophoria. So, this procedure is really only good for those really small vertical deviations. I would not use it for an ESO. You probably need to do something larger, like a central plication or a full surgery.
Yeah, I totally agree 90% of the time. But occasionally, let's say I'm tightening the inferior rectus, which is an adductor, and there's already a micro esophoria, or you're doing inferior oblique surgery, bilateral inferior oblique weakening, which are abductors, and you have a slight esophoria. I might do bilateral medial rectus central tenotomies just to make sure we don't have an induced ESO, because inferior oblique weakening can induce a small ESO deviation. So I will very occasionally, maybe once a year, do medial rectus central tenotomies, but it's super rare because you don't get much. You get 1 to 2 prism diopters on a tenotomy. And the late Alan Scott did a marginal myotomy, and it was interesting. He removed 90% of the muscle. Ening, guess how much change he had? About 6 prism diopters.
Yeah,
Removed
that's the same.
90% of the muscle. As long as some of the muscle's still at the original attachment, you don't get big changes.
So
Well,
I'm going to
we have,
demonstrate.
I think, 14 minutes.
Yeah, I'm going to just very quickly demonstrate. Someone asked a question about what do you do if you have, I think someone asked, how do you avoid non-absorbable suture knot? So I'm just going to see if I can demonstrate that really quickly. It's kind of similar to, um, here, let me see if I can do this here. Ken, are you able to see the question and answers on your end easily?
Yes, but honestly, they confuse me.
All right, so let me focus on this here. So let's say your knot is here, um, and you're worried about it eroding through conjunctiva. I've just randomly put the knot there. This is a nice technique that Dr. Morad from Israel has demonstrated, and I like to use it whenever I'm doing a non-absorbable suture. Hold on to the needle, and you're going to put it through the muscle posteriorly like that. And this is a single armed, I just cut it off, but see how the suture now isn't popping up here, it's through the muscle. And then what you'll do is cut it just barely over the muscle, and it'll lie nice and flat. And actually what ends up happening is the suture kind of retracts into the muscle, and it's like tucked into the muscle belly so that there's no chance of those ends eroding through. So you pass both ends if you've got a double armed through the muscle posteriorly, and then cut the ends long. So I like to do that.
Can I make a comment about that?
Yeah.
So really, that's helpful in a central plication, or I guess even in a full plication, where your suture knot is in front of the insertion, correct?
Correct. Yeah.
So you can pass the suture posterior, so it ends up posterior. But you know what happened to me?
What?
Is because that end is long, that suture end is long, it's directed posteriorly through the muscle, but they blinked and it came forward, and now I had a huge suture in the front.
Yeah, so do you have to make sure that it's yeah, that's the thing. If it's not far enough back, then it can pop through for sure.
So I'm not sure about that. There was a question about iodine. How do you soak it? First of all, the technician soaks it, and what they do is they just take the suture before they remove it from the pack, and they just put it in the iodine, and some just run it through the iodine. It's no big deal. You just want to wet the suture with iodine. And Ning is a good point. Ning brought up a good point. It makes the suture stiff when it dries out. So just add a drop of balanced salt solution, and if you keep the suture wet, it will be soft. But as the suture dries out, it does get stiff with the iodine. But I do it on all my cases.
So I'm gonna try and go through some of the last questions, Ken. Well, we have about 10 minutes left. I think you answered this. In cases of residual sensory deviation, can the surgery be performed on the sound eye? I think you answered that. We really want to focus on just the non-seeing eye. In cases of ET of small angle 15 to 20 prism diopters, do you prefer one muscle recession or two muscle surgery?
If it's a comitant deviation, and then I want to do comitant or symmetrical surgery, so I would do bilateral. If it's and the patient had fusion potential and possibly see double. So on all adult patients, I prism neutralize them. So if there's an ET of 20, I put 20 base out over one eye, and I ask them if they see double. So, and then I'll increase the prism, and I'll see when they see double. So if it's a patient who doesn't see double because they suppress, and no matter what prism you put up, they don't see double, then it doesn't really matter. You can do one eye. But if it's a patient who has the potential for double vision, and you can tell that by prism neutralization, then I don't want to create a problem, especially in an XT, and make them ET and side gaze. So I would do even a smaller XO deviation, intermittent XT with good stereo. That patient, I would do symmetrical surgery.
Ken, do you want to just take a minute to explain what you mean by prism neutralization in case there's some on the call who aren't familiar with that term?
So I have an esotropia of 20 prism diopters. I put a 20 prism diopter base out prism, and you can use a prism bar or individual prisms. And I say, what do you see? And they say, I'm good. I don't see double. Now, what if you put a 20 up with an ET of 20 and they say, I see double? Well, they should be on both foveas. And if they see double, that is a hint that they have anomalous retinal correspondence. And if you correct the full 20, they'll see double. It also tells them that postoperatively, don't be surprised if you see double. Now, if they say with the 20 prism diopters base out, they're neutralized, and they say, oh my God, I see horrible double, I'll tell them that if I operate on you and I get your eyes straight, you're going to see double. And usually it goes away, but not always. Virtually all the cases, ARC, it goes away with time. I've never seen a patient
in quote 40 years that Dr. Ening Strube so insensitively told everybody that I've been doing this for 40 years. But I've never seen a patient in 40 years, when I make them straight, they want to undo it. In the textbooks, except for mine, the textbooks, they warn you about ARC and they're going to be horrible. If you warn them ahead of time that you're going to see double and they still want to do the surgery, I've never seen a patient where I had to undo the correction because of double vision and ARC. How about you, Ening?
Well, I'm a lot
You've seen,
younger in practice than you, so I've also not seen it. And I say the same thing. And I just finished teaching ARC to our residents last week, and I said the same thing. As long as you have good open communication with the patients. I know I pulled you and a few other, um, you know, senior pediatric ophthalmologists who know what they're doing, and everyone had like one or no cases where they had to undo the surgery because of ARC. So it was less nerve-wracking, because when you read it in a lot of the books and a lot of the manuals, it makes you feel like if you can't prism neutralize them, you have no chance of correcting their deviation, which sounds like it's not true.
so when I put the prism up, if they're 20 of ET, I put a 20 base out and they scream, "Oh my God, I see double. Oh, this is horrible." I say, "Look, you're not a great candidate." But most patients, if you hold the prism up there for even 1 or 2 minutes, they quickly say, "I know which is the real image. It's not that bothersome." And the other thing is that you should tell the patients that you'll probably see double for a while after surgery, so they're not surprised. When I was young, I did an intermittent XT and made them slightly ESO. They were so mad. "You didn't tell me I would see double." As long as they're prepared, you got a better shot. They don't like bad surprises, but if you tell them, they'll see, it's very likely that you'll see double after surgery. They're prepared for it. They can relax. And eventually, if it's ARC double vision, it will get better with time. Any
And there
other?
was, yeah,
Yeah.
just trying to address the questions related specifically to what Dr. Wright mentioned in his lecture part. Sufiana asked, is there a limit of plication in millimeters that you do, after which you'll switch to a resection because of the bump?
That's such a good question. I should have mentioned that. Such a good question. For example, if you're doing a Kingston bomb for nystagmus and you're moving and you're doing huge numbers, I do not do plication, full plication. I do resection. So I've heard people do 7 or 8 millimeters plications. I won't do it. The most plication under most situations is 6 millimeter full plication. How about you, Ening?
Yeah, I'm pretty similar. There's not a whole lot of situations other than the Kessenbaum where I need to plicate that much, or sometimes I'll fudge the numbers and do a little more recession and less plication if I'm doing an R&R, so to speak. Someone asked for your case with that patient with a very large esotropia, larger than 100, with cerebral palsy. I think these are the same patient. One person asks, did you do the 9 millimeter recession on a hangback? And someone else asked, did you do bilateral medial rectus recession, or was all the surgery just on that one eye?
Yeah, that was a poor seeing eye with dense amblyopia. So I did a recess and resect. I did 9 millimeter recession without hangback. I did that some time ago, and I actually passed the sutures way back there. You cannot hang back on even on a medial, even if it's tight. You really can't hang back more than 5 to 6 millimeters. Many years ago, there was a paper on how far you could hang back before the muscle just gets floppy. And on the lateral, it's 5 to 6 millimeters. On the medial, it's like maybe 6 to 7 millimeters. But I really like the hangback glue. At first, I was only doing it for the thin sclera, the high myopes. Now I do it for everybody, and my blood pressure is now normal. And I kind of joke, I can do this till I'm 90, because it is so relaxing when you know you're suturing over pars plana, where the medical retina people make millions of dollars when they inject through the pars plana. And so, and I occasionally do adult with sedation with a recession. Not much, but if there's a medical issue, whatever, I will do it topical anesthesia with just mild sedation. And it's so nice to know. And so the patient sort of moved, and I went too deep, and I went right into the eyeball. And I realized I'm over pars plana. It's okay. And I look with the indirect, everything's fine. So it's actually really made me much more relaxed in surgery. But that one case where I showed that huge ET, I actually went back that far. And when you go back that far, you don't use fornix. You use large limbal incisions. Make your incision large.
So I think we have time for one more question, and then we'll have to close it out. But we'll take a look at all these. There was a lot of sort of higher level questions that can't really be answered in the short amount of time, but we'll try and answer those. Or like I said, maybe in another venue teaching session, we'll address those. The last two questions have to do with Duane syndrome, Ken. One question asks, can we have Duane syndrome without eye retraction? And the other question asks, how much is the amount required for a medial rectus recession in Duane with a head turn?
Okay, so if it's a small head turn, I leave it alone. But a significant face turn, or it's actually a gaze preference, a 6 millimeter medial rectus recession for an esotropia Duane's type 1 works 95% of the time. It is a slam dunk. And these patients have great fusion and great fusional amplitudes, and it straightens the head. I have never seen the overcorrection. The late Jampolsky used to talk about a big XT. I've never seen it. I didn't see it in fellowship. I didn't see it in my practice. So it is a great procedure. I wish that the Princess of Saudi Arabia's kid came to me with a big esotropia Duane's, and that would be great. I did have a case quickly come from Russia, and it was a real oligarch. How do you say it?
Oligarch.
Oligarch. Super rich guy comes to me from Russia with a simple esotropia Duane's. I say, look, we'll just recess the medial. It's no big deal, but I can't make it perfect. So I tell the patient, I can't make the nerve come back, which is true. There'll still be abduction deficit, even if you do a transposition. So I told him, I can't make it perfect, but I can make it a lot better and correct the face turn. He didn't like that. He wants perfect, right? So he goes to another doctor. The doctor says, I can make it perfect with a transposition. Well, the transposition induced a vertical. The transposition induced a significant vertical, and the eye still didn't abduct because the vertical muscles aren't abductors, right? In this eye, the eye still didn't abduct. So I had to undo their transposition, and I recessed the medial, and then they were happy. I just recessed the medial. I know about transpositions. I don't do them. What was the other question?
Can you have a Duane syndrome without retraction?
So yeah, so if I have a Duane's syndrome, they have retraction on adduction. Why? Because the medial's firing and the lateral, which should be relaxing, is firing. That's where you get the retraction. So in some cases, the lateral doesn't get much innervation from the medial and the retraction is less. So yes, you can have Duane's type 1 esotropia Duane's with minimal eyelid retraction. That is absolutely true. Usually you'll see some, but sometimes it's subtle. That is absolutely true.
So I just want to take a moment again to thank all the participants for all your excellent questions. We still have 336 people who lasted the whole 2 hours, which is awesome. And I also want to thank CyberSight for giving Dr. Wright and I the opportunity to share some of our new techniques and what we do in our in-person courses. It's really nice to be able to connect with you guys online. And thank you, Dr. Wright, for everything.
Thank you, guys. And I want to thank Orbis. I've been on many Orbis missions. In fact, in the back here, one of my plaques is from Orbis, and they do an amazing job. And I love their mission. Their mission is to teach and leave knowledge behind rather than just do a bunch of cases. It's much better to teach someone to fish so they can fish on their own than to give them a stupid dead fish. So God bless Orbis. It's a great organization. I was with them many years ago, probably 40 years ago, and done many missions with them. So it's a great organization. Thank you, guys. Maybe we can do this again sometime. Thanks. Bye.